Applied Neuroplasticity. I welcome all of you in this neurophysiotherapy masterclass. And the concept that we're going to discuss today is widely accepted today. Everyone knows what is neuroplasticity. The idea behind today's class is to give you a foundation on why it works so well, why physiotherapy foundationally works so well. So there was an old neuroscience dogma, way back in 19th century, that neurons that die stay dead. An adult brain is fixed. That adult CNS cannot regenerate. This remained a dominant belief for over a century, I would say. But now it has been challenged across multiple frontiers, and the evidence is accelerating that plasticity persists throughout the lifespan. And it is an entire scientific justification for whatever we do every day in our clinic. So let us understand actually what is happening inside at a cellular level. Now, as we define neuroplasticity, it is the ability of nervous system to adapt both structurally and functionally in response to the environmental interactions and any kind of injury happening to our body. And what are the key players, I would say, at the cellular level? These are neuronal stem cells, oligodendrocytes, and Schwann cells. Now, they contribute in regeneration, repair, and myelination. Now, at synaptic level, what is happening? The plasticity happens through long-term potentiation and long-term depression, right? Either whatever signals are going, they will enhance and make the signal permanent, or they will delete it. So if repetitive actions are happening, this will lead to a long-term memory, long-term potentiation. Or if there is no signal repetition happening for a long time, slowly and slowly that entire circuit will be depleted. And the rule for this is Hebb's rule, that states that neurons that fire together wire together, right? Now, what happens is that, whenever any kind of memory formation is happening, our synaptic strength is changing. And this process involves complex molecular changes, which include neurotransmitter releases, changes in the receptors, even modifications at the structural level of synapses. And in adults, what's happening is that any kind of memory work is happening for, I would say, just a second, just hold on for a second. So in adults, what's happening? Neurogenesis, that means ability of the neurons to regenerate, it is happening particularly in hippocampus. And hippocampus is the area that gives us cognitive flexibility and emotional regulation. You must have seen some adults who are very, very open to others' ideas, who are not very rigid. They can challenge their thought process, their old belief systems. And even in contrasting situations to what they would ideally find, they can still manage and regulate their emotions. It is happening because of their ability to adapt at the level of hippocampus. Now, what decides this cognitive flexibility? Experience dependent plasticity. That means that reorganization of the existing neural networks can happen through experience dependent plasticity. That means if we are giving various experiences, repetitive signals are happening, changes are being exposed to a person, there would be a cognitive flexibility. Change would happen at a synaptic level, at the dendritic architecture level in hippocampus, leading to cognitive flexibility. Imagine of a person who has never stepped out of their village, and then suddenly they move to a different country. They have been brought up with a certain set of rules, social behavior, food preferences, and various kind of factors which define them as a person. Now, when they are exposed into a different environment, their experience changes. about everything. The entire day's routine changes. People they're interacting with are changes. Clothing, ethnicity, communication levels, behavior, standards, everything changes. When it happens in the first few days, it comes across as a very rigid. Brain feels quite uncomfortable in that situation, but more and more experience they have in that new area, slowly and slowly brain starts to readjust, reorganize, and this experience dependent change in the brain structure is called experience dependent plasticity. Now here with this example, I hope I'm able to make this point clear how human behavior changes, and this all changes happening in hippocampus. There's one more area where magic happens, and now I'm going to shift from the normal human being to a patient level. Like if for example we're talking about stroke, right? So in stroke what happens is peri-infarct cortex. For example, the infarct or the injury has happened in, let's say, MCA area, middle cerebral artery area. Around that area, so whatever area is supplied by MCA, which is affected, area of brain which is in the periphery of that infarct segment, that starts to show reorganization within like minutes, and this reorganization happens in both hemispheres. So the first let's say 3 months that we talk about, the critical window period that we always discuss in clinical concepts, what happens at that time? The window is open to adjust, to change, and then there are some structural changes happening. You all must have heard about it. Axonal sprouting is happening, dendritic remodeling is happening, new synapses are forming, and all of this is happening within first few weeks. Now the challenging idea is that we can involve ourselves in this reorganization process. We can influence this reorganization process by training. We can optimize this entire restructuring happening in the brain. How? We can do that by lot of tools and techniques, and that is what makes it so interesting. Okay, let me give you an example. Let's say there is severe traffic jam happening in one of the posh areas of Delhi. I'm just taking example of Delhi because everybody is mostly aware about that city. Let's say around the India Gate area there is choco block. There's some damage, infarct has happened, and think of it as in brain area where infarct or hemorrhage has happened. Now the vehicles cannot pass through that area. They cannot go towards railway station, they cannot go towards CP, cannot place, and then the traffic from the other side cannot come back here. Also, some buses which used to travel like the ring road structure which used to happen through that, they are also not able to come. So what is happening? Everybody would readjust and reorganize. Traffic coming from far away, the outer areas of Delhi, which planned to come at this area, that would also change its route. It will reorganize, knowing that, oh, we cannot go through that area. So the changes are happening not only at the chock-a-block section, but at the areas which are even far away. Why? Because everything was connected. The signals were coming to the brain through those areas. Even, in the chiasmatic area, it was happening. So now the most important question here is that how can we make this change happening more useful? How can we contribute positively in this reorganization? And does this window shut, as everybody says, after the critical window nothing can be done? No. This critical window doesn't shut forever. Even after late stroke, even after 6 months, years, reorganization is still possible. And trust me when I say this, functional recovery occurs in almost all individuals in response to intense training. Areas compensate, change, and you will see it once you will practice. But you have to prescribe a specific drug. You know what that drug is? Doctors prescribe various drugs, but we physios, the only drug we prescribe is exercise. You know what? Exercise is the thing that we prescribe, but exercise creates such changes in the brain that it is almost in a way equivalent to the pharmacological, substances. And the molecule I'm prescribing, you're going to prescribe, it is BDNF. Yes, it's BDNF. Anyone knows the full form? It's brain derived neurotropic factor. And this is the most important currency for plasticity. This molecule plays a critical role in promoting neuroplasticity. It supports synaptogenesis, it supports long term potentiation, and one of the most powerful ways to upregulate or increase the levels of BDNF in our brain is exercise. But how? How we use that as exercise prescription is what matters enormously. You know what? Recent studies have shown that high intensity interval training, it is more effective to increase BDNF levels compared to moderate intensity continuous exercise. So if you give moderate to vigorous intensity aerobic exercise, let's say 3 times per week, in a proper prescribed fashion, 30 minutes per session for a minimum of 4 weeks. That's how the doctors describe medicines. Take this tablet twice a day and show me after one month, right? So you also recommend the exercise like this. Do this aerobic exercise program I've told you, 30 minutes, 3 times a week, and for minimum of 4 weeks. And when you prescribe exercise like this, it starts showing changes in almost all conditions. Hemorrhages, Alzheimer's, stroke, all kind of conditions. Now, what further enhances this entire experience? Dual task training, cognitively engaged exercises, giving cognitive stimuli during the exercise session, and all these new changes that we do, they add on to the results of neuroplasticity. And even personalized neuroplasticity is being talked about. Personalized neuroplasticity means that you're using the history, preferences, experiences of that person by understanding about their lifestyle, their routine, and using those particular tools, information to design their exercise routine. That will give better results compared to same exercise set for everybody. But there's one enemy you must recognize, and this is a concept most clinicians barely talk about. But I can assure you it is arguably the most practically important concept, and it is maladaptive plasticity. Now, people with stroke often develop a compensatory hyper-reliance on the, let's say, non-paretic side. Okay, and they sometimes do the trick movements from the trunk to perform their daily tasks. They adapt. What is happening in this case? This is maladaptive plasticity. The strong and efficient motor compensation prevents the affected side from generating normal motor patterns. Now you would say CIMT and multiple things we can give, which are talked about. CIMT is also a kind of neuroplasticity principle. And if we we really want to work on the functional improvement, we have to understand this thing, that facilitation of neural plasticity, underlying compensatory learning after stroke also increases use-dependent plasticity impairment of the affected hemisphere. So if you are not letting the paretic side come into picture, not only the patient, because spontaneous recovery is happening, right? So not only the patient will learn to use their non-paretic side to compensate for the affected side, that compensatory training learning is happening, and this will act like a double-edged sword. it will further diminish the ability of the abnormal, or like let's say the paretic side, to ever come up again. You're kind of taking away that chance from the paretic hemisphere. And your rehab is literally going to reshape the brain for better or for worse. So if you're not designing the therapy properly, you would see that in severe compensation, because the patient will figure out a way to do the daily tasks. Okay, so poorly designed therapy which rewards compensation is actually neurologically locking the patient into disability. Remember this, Nain, I'll again say it. A poorly designed therapy which rewards compensation is neurologically locking the patient into disability. That's why we have to learn the principles of neuroplasticity and learn the neuroplasticity principles to ensure we don't allow maladaptive plasticity to happen. So let us be task specific. Let us, instead of going for traditional stroke rehabilitation, work on long lasting motor learning. Let's help in the cortical reorganization specific to the corresponding areas. And it cannot happen without any challenge, like whatever kind of exercises you recommend. If there is no challenge, brain will not learn. But if it is too challenging, brain will not respond. So you have to adjust your tasks, your exercises according to the patient's level. Plasticity is lifelong. Okay, plasticity is lifelong. That's the first learning from this session. The second session is that critical plasticity window is 1 to 3 months post stroke. Okay, and the timing of rehab determines outcome, not just the method. The functional recovery after stroke varies depending on the size of lesion and the timing of rehabilitation. Sometimes, starting too early can worsen the outcomes, they say, but more or less it's like, if you're working on the right exercise needed at that particular time, you will only help. And cortical maps are shaped by what you train. If the training was started 1 month after lesioning, the shrinkage of the cortical hand territory will not happen. Okay, so when you don't train, you lose. Whatever maps are there which are reflecting that particular movement that you're rehearsing, if you're not rehearsing that movement, that map will go away. It will be kind of, body will send that into long-term depression. Potentiation is not happening. What will happen? The reverse thing will happen. Another learnable thing here is that instead of generic exercise, we have to give task-specific exercise. And movement repetition alone is not plasticity. We have to do movement repetition where the patient is active, attentive, and acquiring a skill, is not just moving. When they have to put focus with their senses, you're giving a little challenge to the patient, person will learn better. Learning is better, plasticity is better. And the biomarker like BDNF and nerve growth factor, they actually are the numbers through which we can predict the patient outcomes. So track them. If you're in research, it will be a part of how you do your exercise in very, very near future. So light exercises is an outdated thinking. High intensity interval training within safety limits is the new medicine. And what is the minimum effective dose? Minimum effective dose is 3 times per week, 30 minutes per 4 weeks minimum. But if we can do 100 reps, far better, far better. Adding cognitive stimuli during the exercise session will always provide better neuroplastic results. Don't give your patient a passive walk. Tell them to count. Play a memory game with them. Engage them in a conversation that taxes their prefrontal cortex simultaneously while they're working. And modified CIMT will also enhance neuroplastic changes in the brain by harnessing neuroplasticity and restoring the motor language functions also. It's the most evidence dense plasticity protocol in motor rehab at the moment. And the most important thing here to learn is that maladaptive plasticity is real and dangerous. So don't let the patient compensate around without attempting proper movement. Also, interhemispheric inhibition is an underused treatment target. So when intact hemisphere is there, it suppresses the damaged hemisphere after stroke. Okay, but when you continuously engage in the dual activities, dual tasks, or cross activities, you challenge the intact hemisphere to send signals to the affected hemisphere and enhance the plasticity levels. So the future of rehab is thinking of these tools, and then of course utilizing the technology to help us enhance our entire effort in a goal to achieve increased cortical mapping, right? So what is the entire takeaway from this session? Work on dual task training, work on high intensity interval training. It is emerging as a top protocol for neuroplastic exercise. Understand that motor recovery and compensation are not the same thing. They're two different things. Let us work on true recovery, not compensation. And then technology, or just sending patient to a kind of VR to do the exercises, don't use it as a replacement. Use it as an amplifier. And try to personalize the neuroplasticity, as that is going to be the real, futuristic thing. Think about their daily routine. Think about what they have been practicing. I've had an entire separate session on this topic itself, like personalized exercises, neuroplasticity experience for the patient. But I think this is very, very important thing. And today's session, I hope, has helped you to understand exactly how to make physiotherapy intervention better. So 3 pillars, remember: timing, dosing, and direction. The plasticity window is real. Dosing of intensity, repetition, they are the active ingredients. Give cognitive challenge to the patient. And be more task specific, be more goal oriented, so that you can reorganize the right circuits and reduce the compensation training. Brain doesn't care about what name you give to your protocol, but it does care about intensity, specificity, and repetition. Give it those 3 things and it will reorganize itself. That's what we know. And that is what applied neuroplasticity demands of us as clinicians. Thank you for your time.